Hey everybody, Steve here, Local Level Podcast. I'm sitting here today with Dr. Dan Hidaka. He is a concierge internist and he's a medical doctor on staff at Northwestern Memorial Hospital in Chicago. You can actually visit harper-health.com to learn more about his business and to contact him. So first off, I wanted to have you tell everybody, what does concierge medicine really mean?
So I'm happy to be here. I appreciate the opportunity to come and speak with your audience. So traditional medical practice is based on volume. So in a traditional insurance funded model, you generate revenue based on the volume of people you kind of mill through the clinic. And I use that word mill intentionally because it becomes very mechanized and kind of efficient in the
Right.
pejorative sense of trying to push through as many patients as possible. But at some point, it becomes a little bit counterproductive because the more patients you push through clinic, the less and less time you have to spend with each individual patient. So concierge medicine is different in that it's a membership-based model or a retainer practice-based model where patients pay a membership fee out of their own pocket or through their FSA or HSA, but it's outside of the insurance realm. You still need your insurance, but the physician generates revenue then based off of the membership fee and is no longer beholden to driving volume through their practice in order to generate revenue. And what it does really is it allows for greater access for patients that are members of the practice, and the physician has a lot less patients on their panel. So whereas when I was at Northwestern, I had about 2,000 patients on my panel, I can have about a tenth of that in a retainer-based practice and really pay exquisite attention to each and every one of them, which is what they deserve.
Right. Yeah, one of the things, because we always have these conversations before the show to kind of get a feel for what we're going to talk about. And you brought up the fact that primary care physicians are kind of short-staffed nowadays. It's more, I guess, lucrative for doctors to go into a specialty. And can you tell us a little bit about that issue and kind of how that works for the people that don't know?
Yeah, so in general, in medicine, what's reimbursed is not necessarily time spent with the patient counseling or doing doctoring. A lot of it is based on procedures. And I understand that because procedures can have risks. And anytime there's more risk, they weight that more heavily in terms of reimbursement.
Right.
So there's an incentive from a salary standpoint to go into a specialty. So you see many physicians going through tertiary care academic medical centers going into the specialties because it's nice to be a specialist in one individual area, but it's also nice to earn a bigger paycheck as well. And this is coming at a time when we need more primary care physicians in general, as the baby boomer generation gets older and has more health conditions. We need more primary care doctors. And there's really a shortage of primary care doctors going into primary care, but also primary care doctors who are trained at a tertiary care academic medical center like Northwestern. In my class, I think there were about 45 physicians and about 6 went into internal medicine from Northwestern. So you're getting, I don't want to say less qualified people, but the people with the best pedigree are generally choosing the specialties to go into.
And now, is that something that's based on what exactly? I mean, I understand that there's more risk involved, so obviously there's a higher reward with going to a specialty. But what mechanism is in place that's perpetuating that? You know, I mean, you would think that people would realize that it's important to have a specialized doctor that you see that, you know, kind of has your situation fully understood. So what part of the system is pushing people towards having to go into a specialty as opposed to wanting to, you know, be that primary care physician?
I think it's reimbursement and it's the insurance industry.
Okay.
Even if you look at the physician lobby, 2/3 of the physician lobby are specialists and about 1/3 are primary care physicians. So even what's being lobbied is perpetuating the model that we currently have, where procedures are generating more revenue than kind of seeing patients in the clinic. And there really isn't a regulatory mechanism looking and seeing, you know, we need more doctors in primary care. You know, this is what we're going to do to funnel more people through that path. It's kind of you pick and choose based upon what your interests are when you're early on in residency. Actually, I always found it to be a bit bewildering that or doctors would go into training and within 3 months know that they wanted to be a gastroenterologist or a cardiologist. It was hard enough in the first 3 months just remembering how to be a doctor, not remembering, trying to learn how to be a doctor,
Right.
as opposed, let alone to choose a specialty that early on in their training.
Yeah, I mean that is kind of a strange thing. I mean, with anybody, if you go into schooling, chances are you don't really know what you're there for most of the time. So it's
Yeah, I mean, how many people go into college and they know what they want to do, from the
right,
outset? Or
right,
I would always kind of look keenly at someone or look oddly at someone when they said, the first day of medical school that they knew they wanted to be a radiation oncologist. And it's kind of like that's a super specialized
yeah.
field. How would you possibly know that that's what you ultimately wanted to go into?
And you obviously talk to plenty of doctors. You went to school, so what was the answer? I mean, when you ask people that, I mean, what do they say?
In general, it was my parents are physicians, and they told me to go into a specialty like radiation oncology,
Hmm.
or someone had an experience at some point with an aunt or an uncle who had cancer, whose radiation oncologist made a big impact in their life. So you do get those
Hmm.
interests from those personal stories that people have.
Yeah.
Uh, but sometimes it's a little bit of a head scratcher when somebody knows exactly what they want to do on day one and they haven't even seen kind of the depth and breadth of what's out there in medicine.
Right.
I was actually kind of the opposite. No one in my family went into medicine. So I don't really have a physician in the family that was a role model. And I kind of saw physicians as being jacks of all trades and kind of taking care of the patient as a whole, which is what you do in internal medicine and in primary care. I definitely understood the implications of going into primary care and not choosing a specialty just in terms of salary and scope of practice. Um, but ultimately, I like taking care of the patient as a whole. And I kind of like doing a little bit of everything. I thought it would be boring to just deal with the heart, for the rest of my
Right.
career or to deal with the GI system. I think it's kind of cool that as an internist, I can evaluate someone and work them up as much as I feel comfortable with, and then, ultimately pass them off to a specialty if they need a test or if I really need another opinion. But I'm really able to treat the patient as a whole and kind of use my clinical acumen to try and get to the bottom of what's going on before I pass them off to a specialist. Because once you start seeing a
Hmm.
specialist, you're more likely to get tests, and that's not a knock on the specialist.
Right.
But if you're going to see a cardiologist and you have chest pain, odds are you're going to get a stress test, and I don't fault them for that at all. But as an internist, if someone's having chest pain, there's a little bit more of a margin for error for me in terms of not ordering a stress test. So I feel like I can kind of serve my patients best in terms of minimizing the amount of medicalization that occurs when they start to see multiple different specialists. And patients will
Yeah.
do that. They will kind of fragment their care without really knowing that they're doing it. If I
Hmm.
have a stomach pain, I go to my gastroenterologist. If I have chest pain, I go to my cardiologist. If my shoulder's bothering me, I see my rheumatologist. But really all that does to your care is it decentralizes it and kind of scatters it out, in the ether,
Right.
making it difficult for somebody to take kind of a good overall look at what's going on.
Tell me a little bit about the business side of it, with what you are doing. I mean, you kind of touched on a little bit as far as retainer based thing, but that's a little bit of a new thing. I think a lot of people nowadays with the shutdowns and not having that, people are probably a little bit more hesitant to just venture off and just go get a bunch of tests and things like that. So the telehealth is really big. Having that one doctor that you can call and get your prescriptions if you need one or if you have a question. So tell everybody a little bit about the business side of it. How does that work? How have things changed since pre-COVID and after COVID or during
To be
COVID?
honest, for us, it hasn't changed very much from a business perspective because we generate our revenue based on that membership fee. I think it's changed a lot for traditional medical practice because telehealth initially, I probably was not reimbursed initially, and eventually, or it's starting to be reimbursed now at a greater rate compared to what it was. So that's one major change that's occurred. I mean, a lot of my patients who are seeing specialists now are doing so on telehealth platforms, and before that would not have been reimbursed at a very good rate. And I think that that's improving. From a business perspective, I'm trying to think of other changes to our individual practice. We did a lot of telehealth before.
Hmm.
We do a lot of doctoring over the phone. A lot of the stuff can be done without patients coming into the clinic. We've been trying to keep patients out of the clinic, especially when they're ill, just because you don't want COVID walking through the doors of your clinic. You want your clinic kind of seen as a safe zone or an area where area of safety.
Hmm.
Um, what else did you kind of mean talking about the business model?
So I guess not necessarily the business model, but just the business of it. Why you decided to go this route as opposed to the traditional route of working in a hospital. What are the the differences doing it this way for you as opposed to working in a hospital in the world today, I guess.
I think it's always good to work for yourself, or to be
Hmm.
part of a small company where you have a say in what happens, especially having worked for a hospital, and been in a private practice previously. Um, I only know how to doctor one way. And so much of my decision to go into concierge medicine was not necessarily based off um, salary or monetary issues or the business model. It was more just that, good doctoring occurs when you can spend a lot of time with patients. You can be comprehensive. You can kind of champion their issues and develop patient relationships that last for a lifetime, really.
Right.
And in the previous model, in the traditional model, I was still performing at the level that I would hope and still providing a very good product for my patients, but it was taking a tremendous personal toll on me, both psychologically and physically.
Yeah.
It just didn't seem sustainable. They talk about physician burnout, which is a huge topic amongst physicians. I don't know how much the lay public hears about physician burnout, but that's a real entity that's out there. And I felt like I was on the verge of getting burnt out.
Tell us a little bit more about the physician burnout. That's an interesting topic for the lay people to probably hear.
Yeah, I mean, the rate of depression and suicide in physicians is significantly increased. And part of that, burnout is a term where physicians almost lose their empathy and their ability to to care for patients, to the degree that they had it when they first started out in training.
Hmm.
It's like becoming emotionally dull to what you're doing, feeling like there's not a way out. A lot of physicians' salaries are coming down at a time where they're working harder and harder, and that gets demoralizing,
Right.
and difficult to stomach when you're a physician. So it really is kind of a demoralization of the spirit to practice medicine is what they mean by physician burnout. And then certainly physician burnout leads to depression and other mental health issues.
Yeah. Yeah. I mean, when you have somebody that you go to care for you, you expect that they're in the right frame of mind. You just assume that, I feel, and I'm I would imagine it's really easy to, I guess people just take that for granted. It's really easy to overlook. Hey, this is a human that I'm speaking with too. It's not just a robot that's a medicine robot. So that's a good segue into kind of like the style of medicine that you practice. Because when you were talking about what really gets you going, it's that paternal type of treatment that you give to people, the bedside manner, the closeness, kind of having a connection with your patients, to walk them through to a solution that overall will serve them best. Tell us a little bit about your particular style.
So I think I'm relatively laid back, but I also think as you said, I'm very paternalistic over my patients. I really want to champion their issues and own their problems. When you talk about increasing subspecialization in medicine, there's a lack of ownership over the patient. So when the patient comes in and they have a problem, that's my problem. It doesn't matter if it's under my purview or not. I mean, as a primary care doctor, it's always under my purview, but I'm going to help them seek out whatever treatment is necessary or whatever specialist they need to see. The other thing is, it was really bothering me when I was so busy that patients would call and try and get seen for an acute issue, and I wouldn't be able to see them because you
Right.
can only add on so many patients in the day. And it really bothered me that the reason that you have a long-term relationship with your physician is so that when something goes wrong, you've got your physician who you've vetted and you've picked for a particular reason to see.
Right.
And I was really failing my patients in that. And that was taking its toll psychologically on me, wanting to be there for my patients when they're ill or when they're admitted to the hospital. That's another kind of area where we're not doing the best job in medicine of continuity of care. When patients are admitted to the hospital, now they're taken care of by hospitalists, and their primary care doctor isn't often in the loop in terms of what's going on. And this can be for pretty significant life-changing things that occur with, big questions that patients have, and they need help from someone they know to try and navigate the healthcare system. So when we talk about practice style, I like to be paternalistic. I like to own my patients. I like to be there for my patients. I also like to treat all my patients as if they're family members. I think that goes without saying, but patients will always ask, you referred me to this general surgeon, who would you send your mother to? And my response is always, I'm treating you as if you were my mother. Right. So it's kind of, I have a very hands-on approach. I like to think I have good relationships with my patients. I know my patient's medical history. I don't have to look through their chart before I give them a call. I kind of know what makes them tick. I know, that they have 2 children, what their names are. Those are the things that you kind of take a lot of satisfaction in your job with, just kind of intimately knowing your patients.
Yeah. And so much of the healthcare in my experience is just very clinical, and there's no personal real connection. You're in, you're out. You might see the doctor for a minute or two, ask you a couple questions, but you're mainly dealing with a nurse. And that just seems like we could do better. But at the same time, it's a hard job. And like you said, a lot of these doctors are probably overworked and underpaid for a lot of things, especially the ones in the ER and, in clinics and things like that. So it's an interesting world, especially in the world today with everything going on. Now, I've been waiting to ask you about this, but I wanted to get a little bit into the current events, what's happening, what your experiences are dealing with people. One of the things that I always ask people when I talk to them is, how many people do you personally know that have gotten sick with COVID?
So I know 4, all of which were patients. I have yet to have an acquaintance that I know outside of medicine that's had the virus. We had one patient in our practice who was very gravely ill and was in the intensive care unit, but pulled through, did well. The other 3 patients that I know, just within my smaller practice amongst the larger Harper Health practice, I was able to treat at home. They had high fevers, they had lots of body aches. It definitely knocked them off their feet, but they weren't sick enough that they needed to present to the hospital, thank God. But I think, to your question, it seems as if the virus is out there, but a lot of people don't encounter it. So it almost seems like it's not real, right. But it is out there. And unfortunately it's altered the way that we live for the foreseeable future.
Yeah. Yeah. And it's kind of that thing, you don't really know how bad it could be if it never really gets that bad. Right. So that's always a problem, with people's perception. It could be the worst virus in the whole world, but if you don't ever see it or know anybody that's had it, it can't be real, to people, right. Mentally. So that's why I wanted to speak with you, because you deal with people, you're in the profession, treating people. So what you're saying is, you've had 4 people that actually tested positive. How did that work out? Did they come in with symptoms? Did they just get a test and not have symptoms, without going into specifics? But
they came in with symptoms, and nowadays we're able to do the drive-through testing. So we can order drive-through testing that can be done at Northwestern. Some of the drive-through testing we were doing out at our Hinsdale office. We were literally walking down to the car and swabbing patients. Most of my patients were positive later on in the outbreak, when testing was more widespread and we were able to secure a diagnosis for them. I should say I hear about a lot of COVID from my patients. You get a lot of 6 degrees of separation. I was with somebody last weekend and they were with somebody else, and that person had COVID. So now should I get swabbed? It's out there. There's lots of questions that are coming from people that have come into contact with it. And if it's hard, because if you've got a small little pod that hasn't been exposed to it, it seems like it's not really out there.
Right. Right. And now, have you been, for the most part, I guess just the anecdotal things, the people telling you this and that through their experience, has it been, have you heard of many severe cases, or has it just been a positive where they really just don't feel good, but it's not life threatening?
No, I've heard of a lot of severe cases. I mean, the intensive care unit at Northwestern was not at capacity, it was close to capacity. The hospital did a very good job in their surge capacity of expanding their ICUs, but there were a lot of patients who the intensivists were describing were gravely ill with COVID. And this is definitely not the flu. This is worse than the flu, which is a point that they continued to make when I would talk to them, just in terms of the patients that they were seeing.
And how were they coping with it? Is it something that were they noticeably disturbed by it, or because there's so much uncertainty? I would imagine if they're in contact with it, they kind of are worried for themselves a little bit.
Yeah, I think it was hard, especially early on, because we just didn't know very much about managing it. We know a little bit more about managing it now than we did. But I think it's hard when you see somebody that's very, very ill with something that you're not very educated in.
Yeah.
They didn't necessarily express as much to me, but I think kind of on a granular level that seeing it in the flesh must have been a little bit of a jarring episode for them.
Yeah, definitely. Whenever you come into contact with something new, especially, I mean, I don't know about you, but when this first kind of broke out, we were getting the news and the reports. I think I definitely thought it was going to be much worse, faster. I thought it was going to be a catastrophic event, the way that they were, making it out to be. How did you deal with it when it first came out? When the news broke, what were your thoughts on it in the beginning, as opposed to how it is now?
I think it's difficult as a physician when you get a lot. I mean, I get a lot of my information on COVID from the media.
Right.
So it's difficult because sometimes patients seem like they're more educated about COVID than you are. And I don't think they're actually more educated about it, but they may have heard about treatment X or treatment Y that maybe I didn't hear of, that was obscure on the CNN website. And as a doctor, it feels a little bit invalidating when your patient brings up a potential treatment for something, despite the fact that it hasn't been validated in a large population or it hasn't been in peer-reviewed medical literature. But it feels a little bit invalidating to not necessarily know the exact thing that they're talking about, right? Because the evidence is coming out so quick, or not the evidence, the research or the thoughts about COVID is coming out so quickly that it's hard to stay on top of everything. I think now looking back on it, I have a better sense of the clinical course of COVID than I did before. Mm-hmm. And it definitely feels more real now than it did early on before I had any patients that had COVID.
Mm-hmm. Yeah. I agree. I think that whenever you're dealing with the unknown, it's much more scary. But when you kind of get a feel, when you feel like we've gotten texting, kind of worked out. Overall, we know that the deaths are much lower than we originally thought they were going to be, which is great. And what I hear is that it's very contagious, and a lot of people probably have it, don't even know they have it. So do you feel better? Do you think that we're getting in a better place, or do you feel like we're maybe getting complacent? And what are your thoughts? What are your opinions?
I feel like the latter. I feel like we're getting complacent, and I think there might be a second wave. I worry about the fall with influenza season coming, that there's going to be COVID and influenza, and we're all going to be more indoors and closer proximity than we've been able to be throughout the summer, where we can kind of meet in outdoor events in the environment where it's harder to transmit the virus. So I tend to be with the latter, that I worry about people becoming more complacent, and there being a second wave coming in the fall. And I think it's hard, because you think about how this is going to ultimately end up. When we eventually get a vaccine, I don't see a large number of people being vaccinated until at least early 2021. So I think it's here with us to be our reality for the time being, and probably for the next year or two, because even when the vaccine comes out, not everyone might choose to get it, and it may not provide 100% protection.
Right. Yeah, it's a cultural thing, in the United States that we are hesitant to really trust authority for the most part, or at least blindly. So yeah, I mean the vaccine thing is kind of a touchy thing. I mean I can understand both sides of the argument, um, but knowing that there's going to be a huge pushback against that, taking it, accepting it, or adopting it early, does it seem like maybe it almost is a guarantee that it won't be as effective? Or what do you think? I mean,
I hope not. I mean, I hope it's going to be the minority of people who are going to be willing to get this vaccine. But to your point, I mean, if you don't have someone in your pod or close acquaintance that's had COVID, you may not believe that it's really out there. And to your point, we may have done a good job of flattening the curve, and it might have been much, 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 much worse had we not done that.
right.
So I think it's difficult, especially in the United States. People are going to want to keep their autonomy and do what they want to do. I think to digress a little bit and talk about patients that were asymptomatic with COVID. I mean, I've heard multiple stories from the emergency room where somebody's in a car accident and they've got shoulder pain and they end up getting a chest x-ray and they've got florid COVID pneumonia without any symptoms. Or patients that are getting chest x-rays for other reasons and they've got COVID pneumonia, they don't have fever, they don't have any other symptoms. So it's out there, and patients have it and are infectious and not having any symptoms from it.
Yeah.
It still looks like the seroprevalence rates, when they look at it, are still in the single digits. And really, to get to herd immunity, we need somewhere around 50 to 60%. So we're still a long way from where we need to be. I think testing has gotten better. Our testing capacity has gotten better, but we still need more testing, especially in the fall, trying to differentiate between what's influenza, what's respiratory syncytial virus, what's COVID. I think it's going to be a challenge.
Now, see, the thing about testing, so this is a question that I kind of had, and I think a lot of people are wondering about this too. We hear about all the different types of tests. There's the rapid test, there's the antibody test, there's all these different tests. What is the standard now? Like if you go into your doctor, or say if you come in to see you and you want to test, could I come into your office or have you come to me, or however it's going to work, and request a test and get the results when? How does that work?
So it depends. It depends if you're symptomatic. If you're symptomatic, I'm not going to have you walk into the office at all,
Okay.
right? Because you're potentially infectious. I might do drive-up testing with you or send you to Northwestern. So there's molecular testing, which is actually testing for the genetic code of the virus. And that is very sensitive and very specific. That's what's done at Northwestern. That's what's done through LabCorp, which is the vendor that we use. The turnaround time at Northwestern recently has been very, very good, 1 to 2 days to get a result. And through LabCorp, there were periods of time where it was taking 5 to 6 days, but we're kind of back to a 2 to 3 day waiting window to get our results back from our private vendor. And you talk about other tests. So the rapid test is not nearly as sensitive, meaning it's going to miss certain cases. It's going to miss a large number of cases that are out there, but it's better than not having anything, because when it is positive, it tends to be correct.
Okay.
The other test that people refer to is the antibody test. So that's looking for signs that you had the illness, later on in the course of illness, or once you clear the illness. It's looking for antibodies against the virus, indicating that you were exposed.
Mm.
And then amongst those antibody tests, right now there's only binding antibody assays, I believe. We don't know if the antibodies that we're assaying right now are neutralizing antibodies, which prevent infection.
Yeah, there's still a lot of uncertainty, but I know a lot of people are working on it. Everybody in the world is kind of thinking about these things right now. So I'm confident we'll get it sorted out one way or another. What are your thoughts on herd immunity?
I don't think we're going to get to herd immunity for a long period of time without a vaccine. My hope is that when a vaccine is available, it'll be used by people that are capable of getting it.
Right.
Yeah, I guess I don't have any other thoughts about herd immunity.
Yeah.
Other than that, it's happening slowly. I mean, when you look at the seroprevalence rates, like I said, they're in the single digits, and they need to be in the 60% range for us to establish herd immunity. So I kind of think if we if we let it be without intervening with a vaccine, it's going to be quite some time before we get there.
Now, the hospital system itself, you kind of touched on it a little bit as far as the, the surge control, making sure that there's enough, available capacity. How has that been managed? Obviously we live in a large area, so we have a lot more capacity, but we also have a lot more people. What does that look like? Do you think we're prepared for something if it were to happen in the fall? What are your thoughts on that?
I think we are. I mean, I know Northwestern in particular was bracing for the worst, and they still, even at their peak census, had beds available. So I think the city of Chicago has done a good job of allocating what beds we have available, the ICU beds versus the medicine beds. Mm-hmm. Our surge capacity in Chicago seems to be pretty good. I think you never know what the future is going to bring, but I think we're well positioned to handle an increased amount of cases should they occur.
Okay. Yeah. And we cross our fingers. Obviously, we hope for the best, but prepare for the worst. So that's good. So I wanted to get into preventative measures, ways to set yourself up for the best case if you do get it, to put yourself in a position where you can fight it off. What are some of the things that you can do at home? What are some of the maybe vitamins or something that you can take, supplements that might help strengthen your immune system? What would you say would be a good thing to maybe look into?
So there's not a lot of evidence on treatments that you can do to reduce your chance of getting COVID, but something that we anecdotally tell our patients is to take vitamin C or take vitamin D on a regular basis. I think it's overall healthy living. When you're stressed and you're run down and you're not taking care of yourself, that's when you're more susceptible to getting infection. So kind of doing daily maintenance just for mind and body, I think is important. And then, the part that's under your control, which is who you expose yourself to, is huge in terms of what your risk is going to be to contracting COVID, right? So if you're good about wearing masks and staying outside of a 6-foot radius of other people, your risk is going to be relatively low. If you're in someone's company within 6 feet without a mask for more than 15 minutes, that's a pretty significant risk that person might have COVID and that you could potentially catch it. So there's a lot of things that are under a patient's control in order to kind of minimize their risk of catching the virus.
Yeah, it's it goes without saying, if you're living a healthier lifestyle, you're probably in a better situation to fight off any illness that you have. So, maybe drinking a little too much and smoking are things to maybe consider quitting, I would imagine. How do you feel about the fact that, from what you hear, alcoholism and, kind of the depression setting in of being maybe laid off or at home for an extended period of time, how has that been playing into things? What are your thoughts on that kind of
There's
thing?
been a lot of anxiety. People are really afraid of catching this disease, especially the seniors or the over 65 population. I mean, there are people that are just barricading themselves in their apartment or their condo and not coming out. So there's a lot of anxiety that's been out there associated with it. I've dealt personally less with depression associated with the pandemic. I think as we get into the winter months, that's going to be more of an issue when it's dark outside all the time. You're not leaving your apartment. You're not you can't see friends and neighbors and family. I think it's going to become a much larger piece of the puzzle that we're going to have to tackle as we get into the winter months.
Yeah, I agree. It's an interesting thing. I think that we've overall, I guess, let me get your opinion. Overall, how do you think we've handled it as a society? You think good, bad? What do you think?
I think in the United States, we could have handled it a lot better. I think that without getting into politics, I think if we had a unified effort coming from the federal level in terms of how to handle this, we'd be in a much better situation than we are. I think we've done it. We did a good job of flattening the curve in Chicago and preventing, the hospitals from becoming overrun. So we have done good things in the pandemic, but I think that it could have been handled much better than it has been. I think when you look at like New Zealand, who really has watched who they've allowed in and had a very strict lockdown. I mean, they had no cases for a period of time, and they're able to be in large arenas watching sporting events.
Hmm.
That's something that maybe would have been on the table for the United States had we had a better, more unified federal guidance when this happened, and much earlier than it happened. So it's hard to kind of know how we're doing on that metric. Because as you said before, maybe it could be a lot worse. Maybe we're doing really well.
Yeah, right. We don't.
But
Right. Yeah. It's that's the thing. I mean, there's no way to really tell. There's no reference point. But
well, I mean, you could use Italy as a reference point,
that's
right?
true.
I mean, they were literally choosing. Doctors were having to make life and death decisions about who they were going to resuscitate and treat. And it never got to that point in the United States. So from that perspective, it's a huge win for us.
Yeah. I mean, we saw in New York, they had terrible news coming out of New York. A lot of people passed away. It's a crazy time, but one of the things that's being suggested that we probably, and I want you to get your opinion on this, is really focusing on protecting the elderly and the most susceptible. What do you think, if, for an average person, if you have grandparents or, older friends or things like that, what are some of the steps that you can take to kind of, isolate those people in a healthy way? Or what are some of the things that you could do yourself to, maybe protect the people around you?
Well, I think it's not exposing yourself to them or not exposing them to you. I think it's wearing a mask, staying outside of 6 feet from those individuals. I mean, it's easy now because the weather's nice and you can still see grandma or grandpa or mom or dad or, aunt or uncle outside,
Right.
where the risk is much lower. I think you're going to have to take a self-assessment of how good of a job you're doing within your pod of not exposing yourself and thinking whether or not you're high or low risk, and then based on that, making a decision as to whether or not to enter the house. Right, wearing a mask. I think you should be masked. They should be masked. You should avoid coming within 6 feet of them. Those are they're hard decisions because they're so personalized. Each and every one of them is. That's one of the benefits of concierge medicine, is those are questions that we get that we can help patients answer. It's as simple as just shooting us a text of saying, hey, I was thinking about seeing grandma this weekend. What are your thoughts on what the risk of transmission is? And we can kind of tackle that with them based upon the individual circumstances, because it is such an individualized occurrence when it does happen.
Yeah. Yeah. And I wanted to move on to that a little bit, to get, really, really hit home what it is that you do and the difference between taking that risk potentially to go to the hospital and, to do those things. So tell me about how you actually operate. You have an office that people can come to, but will you also go out to the patient and see them on location? Tell me about how it works.
So yeah, I mean, we basically do whatever we need to do to take care of the patient. So a lot of my senior citizens, I've made house calls for. I've made house calls just to draw their blood if they needed blood drawn for another reason, just so they didn't have to go out of their apartment and go to the hospital and get it drawn. We've brought a lot of patients into the clinic to do things, in lieu of them seeing specialists. So I've injected knees, I've injected shoulders. We've brought patients into the clinic because we're a very low volume clinic and the risk is very low of contracting COVID in and around our clinic, as opposed to if we were based out of the hospital where there's maybe more chance of coming into contact with it. But it's spanned the gamut of, telehealth, texting, making house calls with patients. It's really whatever the patients need. And then when they're hospitalized, trying to see them in the hospital, which initially was problematic with the pandemic, not wanting to use PPE for social visits and things of that nature.
Yeah, one of the main reasons I led into this with what we can do to protect older people or people at a higher risk is, the fact that you will do house calls. You can cut out that whole risk factor and the hesitation specifically for people that maybe do need care for other things. Maybe they're neglecting their, checkups or just screenings that they would need. You offer solutions for people to kind of not have to worry about going in and sitting in a waiting room or whatever. Can you tell people about some of the things that you would suggest that they call if they're at a higher risk? You would suggest that they contact you, and kind of the benefits of doing it your way as opposed to the old school way?
Yeah, I think that there's a lot to be said for the state of mind that they know that you're there for them. And should they become ill, you're there to kind of guide them in terms of what to look for at home, when they should come into the hospital, if they need to come into the hospital, and that you're there for them when they're in the hospital, helping to coordinate their care. Um, I think that goes with any illness. It doesn't have to necessarily be COVID.
It seems to me that in the world that we're in today, we know that there's a group of people that are at a higher risk, and I would imagine if I was one of those people and I was at a higher risk, I wouldn't want to be going to get a checkup. I wouldn't want to be going to whatever it is, any procedure or something that I could put off, I would put off.
We can help determine, for each individual patient, what is appropriate to put off and what's not appropriate to put off.
Right.
I think patients, unfortunately, there's less heart attacks coming into the emergency room, less strokes. And I think a lot of that is because patients are at home so concerned about catching COVID that they're not coming in for the cardinal warning signs of certain other health conditions. So
Right.
I think being able to use this as a sounding board for whether or not they need to seek additional care for some of their complaints is a very valuable aspect of the concierge care that we provide.
Absolutely. Yeah, that was nicely put. It is important. I mean, it's not something you think about. Whenever you think about concierge, you always think of specialized, tailored, personal, direct to the source. So tell me a little bit about the process of becoming one of your patients. What is the intake like? Is there a process or a form or application approval process? How does it work?
So it starts with a phone call with the physician, just to see if we're aligned. What we used to do was do meet and greets in the office, but in the age of COVID, we do that over teleconference, or we do it over the phone to try and figure out if someone's a good fit. And I think patients should be aware that they're interviewing us, but we're very much interviewing them as well, because we want to make sure that their expectations align with kind of what our expectations are for good care.
Mm-hmm.
And once that visit has occurred, then there's an onboarding process where they sign a contract. We talk about what the concierge fee is for the year on an annual basis, and we kind of get them plugged in with the electronic health record, with our communications devices. We have HIPAA secure, encrypted ways to text our patients and receive text back, to kind of get them onboarded to all the individual technologies that we've got within our office. And then it's bringing them in, or doing a video health conference, just to take a history and get to know them. Also to gather the medical records, just so we've got a good background history on our patients as they come in, and schedule a physical. We're still doing physicals. And we put a lot of value in our annual physical as kind of the starting block for what we want to be promotion of good health, not just reacting to disease.
Yeah. Well, that's something that I wanted to also talk about. Having your health taken care of, and not just going to the doctor when it's catastrophic and on death's doorstep. It's a relationship that you should have in place. You should have a doctor that you trust, that you're in communication with semi-regularly or whatever, doing what you have to do. And that's kind of what you built your whole thing about. I mean, that's really the core of what you do. It's that it's a different type of medicine. It's that personal care where I can call you, I can text you, and I can get an answer from you direct. Is that about right?
Yeah, that's correct. And I think the other thing that I said before is, we want to get away from reacting to disease, and we want to get in the habit of promoting wellness.
Yeah.
Right. So that can be me checking in every 3 months, just to make sure that if I recommended you exercise a little bit more, or tweak your diet in a certain way, that can just be a follow-up phone call from me, trying to hold you accountable. So part of it is the science of behavior change, understanding that, knowing that maybe we need to be in a certain patient's ear a little bit more, to get them to push them in the right direction. For some of the chronic health conditions that they have, I think some of us have a different view on them altogether. Like type 2 diabetes is not something that should be treated. It should be cured because it's a curable disease. I think when you're, when you've got 25 patients on your schedule and you've only got 5 minutes to spend with somebody, it's really easy to write another medication that's going to perpetuate the disease process. It's much more difficult to spend 30 to 45 to 60 minutes with the patient, really telling them this is a curable disease. You don't have to suffer from this any longer if you do X, Y, and Z. So it's very powerful having the time to be able to do that with our patients, and really come at it from a wellness approach in addition to managing chronic health conditions.
Yeah. One of the things that we touched on when we had our conversation last week was the trust factor. The fact that since those interactions are so short and it's with a different person every time, most of the time, you don't have that eye to eye, kind of personal trust in the person that's given you the, recommendations. That's so important, with something as important as your health. You would think that the system would be based on that personal touch approach. Why is it not? I understand the specialist thing, that angle, but what can we do to change this? Do you think that concierge medicine and the personal care type of thing is more of the future, or what do you think?
I do think it's more of the future. I think the hard part is that concierge is going to eliminate certain, by virtue of the fact that there's a retainer fee, you're going to eliminate a certain portion of the population that isn't able to pay for it. And I think that's a difficult avenue to think about in terms of what the future is going to look like in terms of trying to get more personalized care for individuals. I think ultimately it comes down to what reimbursement is doing. I think if reimbursement starts making it advantageous to spend time with patients, I think you'll see more personalized care out there. We can talk about the future of healthcare. I think one of the things that you and I had talked about last week was maybe there will be universal healthcare. I would argue that it would be a good thing that we get universal healthcare. But in a universal healthcare system, I also think in the United States, we should offer more. There should be a secondary insurance market or a concierge market. I think you're going to see a niche for concierge type services as an add-on to what's considered basic care.
Yeah. Yeah. One of the things when we ponder these things, about how you can, just the logistics behind offering healthcare to everyone across the board for free or whatever, universal out of taxes or whatever it is. There's just so much waste in the government. A lot of times there's so much, there's so many moving pieces that it's like, how can you trust that they all fall into place and it works every time? I don't think that's possible. But one of the things that was really interesting when we were talking about the fact that if you have that personal care and you have that person that kind of has that overall perspective of each individual patient's case, you're not necessarily, number one, you'll be able to prevent a lot of things before it happens because you'll have that trust factor and people will actually listen to you. So that'll cut down the amount of need, people will overall, I would imagine, be more healthy. But unfortunately, what happens is that takes a lot of money away from the drug companies and the insurance companies. And if we want to actually solve these problems and provide healthcare, it's not about whether it comes out of our taxes or how it's going to get paid for. It's where does that money go, and why does it have to be so much,
Right. We don't insure all of our citizens, and yet we're spending more per capita than any other country. So
right. Yeah. And the other aspect of it that I hear from physicians, and I think we talked about this too, is the fact that, if you're going to take that extra time to give that bedside manner, you need to be compensated for it as well. You can't, expect, you go to school, you can't be forced to provide more service to everyone at a lower cost. That is not right. So, there has to be some sort of reworking of this whole kind of drug pricing system, insurance system, because I think that's the problem. A lot of it, or part of it. There's so many pieces to this, but it's. I think it really starts with just having a trustworthy physician that actually, understands you, your individual case. I think that'll solve a lot of things.
Well, I think to your point, I think it cuts down on waste. It cuts down on repeating tests. I think
Right.
when you have multiple different cooks in the kitchen, a lot of tests get repeated, sometimes at different facilities because we don't have a unified medical record or one standardized medical record.
Yeah.
Somebody shows up in the emergency room at Northwestern, but was at the emergency room at University of Chicago 2 weeks ago. We may not have the information of what happened at that visit, and that may really alter what we order for this admission or
Right.
for this patient when they're in the emergency room this time. So I think cutting down on the repeating tests is certainly one area where we can limit the kind of waste healthcare dollars that are kind of going by the wayside.
Now, one thing that you brought up just for your individual business, you are part of the Northwestern system. So what was it exactly that you said that where you actually have access to records if people are within the network of some sort? Can you explain
Right.
that a little bit?
So I'm at staff. I'm on staff at Northwestern Memorial Hospital. I'm not. I do not work for
Okay.
Northwestern Memorial Hospital, but that allows me to have access to their medical record, and so I can directly kind of plug in and look and see what's been done in any Northwestern based care. It also allows me to see, it's a system called Epic, and it also allows me to see care that's being delivered at other institutions that have Epic. So it is allowing me to kind of plug into the mainframe and get a lot of the data that I need to get for patients.
Mm-hmm. Yeah, and with anything, obviously there's two sides of everything. Whenever you talk about collection of data and sharing of data, you have privacy concerns. HIPAA is supposed to be there to protect patients. Can you tell us a little bit about what that does? I know it's a big, complicated thing, but just tell us a little bit about how those rules work, and how secure is your information if it's being shared.
Well, you have to sign a HIPAA form to download any information from a different institution using Epic, but it makes it very difficult. I mean, we want to make sure that we're keeping people's health information and personal information secure. And I think that's one of the barriers to us having a unified medical record is because of
Privacy
those
concerns.
privacy concerns.
Yeah, yeah, but at the same time, there are some things that you kind of need. I mean, if you're a doctor and you're going to be providing care and you're going to be ordering tests and all this stuff, all this waste, there should be some sort of information you should have access to, just at the very least for the patient's protection and for yours. If you're going to be prescribing things, you need to have all the information. Otherwise, you could get sued or you could kill somebody or hurt them badly. So it just makes a lot of sense that there should be a lot of changes. We've been talking about this for so long, about how we're going to overhaul the healthcare system and all these different things. What do we see happening? Do we see changes on the horizon? Do you think that it's something we can ever accomplish, or are we just spinning our gears?
I think that's a difficult one. It took so much to get the Affordable Care Act passed. I think we'll have to see what happens in November. I think if the Democrats get a hold of the presidency and the Senate and the House, I think you might see some legislation put through in terms of universal health care. But I think it's a difficult nut to crack. It's something, you're right, that we've talked about for a long period of time and everyone agrees about, but no one agrees on the solution.
Right. Yeah, it's well, we all have different perspectives, and that's why I wanted to hear yours. I mean, you're in it, you do it. It's important work. I mean, we need doctors that care. We need doctors that provide, real service, face to face type of stuff where I know who you are. I can call you if I have a problem. So tell everybody how to contact you. Let everybody know exactly, what you have to offer. And, I definitely enjoy our conversation.
Yeah, I very much appreciate the opportunity to come on your show and talk. The best thing to do is to go to our website. It's www.harper-health.com. And you can call us or email us. You can put in your information, learn more about our practice. You can even download, I believe, a sample contract to get more information. And we're happy to hop on the phone with anyone that wants to be a prospective patient, just to touch base and see if our expectations align with what you're looking for.
Absolutely. Yeah. And, I mean, it's an important thing. I know that you do care. You like you said, you were on the verge of burning out because you felt like you weren't able to do as much as you wanted to do. So now that you have a little bit more control and you have your own thing, I think that's a win for everybody. So
Yeah, I think the work-life balance has been a lot better since I've made the change.
yeah, well, that's good to hear. How's everything else in life though? Are you okay? Is everything good? Or
Yeah, things are good. I mean, I have two small kids. They're 6 and 8. They're totally healthy.
that's good.
My wife's a pediatrician and her practice is doing okay. Things are good. I mean, I think in the world of COVID, that's the disclaimer, but I think things are otherwise very good.
Yeah. Yeah. And I want to leave on a positive note. I think that there's a lot of learning, that's going on right now. I think people are kind of, even through all the negativity and all the things going on in the world, I think that, we all kind of want the same thing. We want happiness and health and, for our family to be, good and people are generally good. So, I definitely like to hear these stories, but I'm glad you're doing well. Everybody, again, it's harper-health.com. Dan, it's a real pleasure to have you on. I really, really appreciate it. We'll be talking again soon.